Let's talk about magnesium sulfate. So if you recall, magnesium sulfate is used in the treatment of preeclampsia with severe features. It's also used in the treatment of preterm labor. With preeclampsia with severe features, remember our concern is preventing seizures. If the patient has a seizure, now they have eclampsia. So the medication that we give them to prevent that is mag sulfate. It's only used if there are severe features of preeclampsia. When we give it, we give a loading dose followed by a maintenance IV infusion. The loading dose is usually 4 to 6 grams over 20 to 30 minutes. That's determined by the provider. The maintenance rate is usually 2 grams per hour. So when we're giving that loading dose, the important things to remember are that you're giving a huge amount of magnesium sulfate in a very short amount of time. So the nurse needs to stay at the bedside the entire time. The patient should have a continuous pulse ox on, and you need to be doing frequent vital signs. So most policy and procedures will call for every 5-minute blood pressures, respiratory rate, and potentially deep tendon reflexes. Because again, we're giving a huge dose of magnesium sulfate in a very short amount of time. It's a high-risk medication, so it needs to be double-checked by 2 RNs at the bedside with all rate changes and at the initial infusion start. Your assessments after that initial loading dose, again, are going to be dictated by your hospital policy, but typically you'll be doing vital signs, lung sounds, and deep tendon reflexes and urine output hourly. When a patient's magnesium sulfate blood levels get to a certain point, they will start exhibiting symptoms, signs and symptoms of that. So you'll see first their deep tendon reflexes will diminish. So that's why we're checking hourly reflexes. Then their respiratory rate will slow, and then they'll start showing cardiac abnormalities. So if your patient does develop magnesium sulfate toxicity or overdose, your antidote is calcium gluconate. So you need to have calcium gluconate easily available in case your patient starts getting mag toxic. Potentially you'll be drawing mag levels every 4 hours because you want to make sure that they're at a therapeutic level but not toxic. So the goal is to keep them in that 4 to 7 milliequivalent per liter range. However, if you're doing good assessments, you should be able to tell if their mag level is getting too high. They also will be really lethargic, so a high risk for falls. So again, with mag sulfate, you're doing really good close nursing assessments, assessing their deep tendon reflexes for multiple reasons. One, to make sure that their reflexes aren't diminishing. That would tell you that their magnesium level is getting high. Also to make sure that their reflexes aren't getting worse or more hyper-reflexic, which could tell you that their preeclampsia is progressing and getting worse. And you're doing lung sounds to assess for pulmonary edema. You're doing respiratory rates. You're doing neuro checks. All of those are going to be hourly, as well as urine output. Magnesium sulfate will be infused for 24 hours after delivery, and then it will be turned off. If it's being used for preterm labor, the protocols are a bit different, but if we're using it for preeclampsia, standard is to run it for 24 hours after delivery and then turn it off. That's it for mag sulfate.